cardiologist on hyperuricemia and cardiovascular risk with this study that carried out on Algerian population. Uric acid is a heterocyclic organic compound with a molecular weight of 168 daltons. Many enzymes are involved in the conversion of tupurine into uric acid. Two enzymes are important: xanthine oxidase and hypoxanthine guanine phosphoryboside transferase. In humans, there are several mechanisms to regulate uric acid level. One is excretion by transporters in the kidney and in the intestinal tract. The other is increased activity of AGPRT. Etiologies of hyperuricemia. One, overproduction, for example, diet rich in purine. The other is decreased uric acid excretion, for example, in chronic kidney disease. Many epidemiological studies has shown association. Many epidemiological studies has shown association between hyperuricemia and atherosclerosis related event. Additionally, fundamental studies have characterized the role of uric acid in the pathogenesis of atherosclerosis. Note that uric acid is an antioxidant in extracellular space. However, intracellular uric acid induces oxidative stress. The mechanism by which oxidative stress accumulates are as follows. Reactive oxygen species are produced by xanthine oxidase activity, and NADPH oxidase expression activity increase. Mitochondrial reactive oxygen species are produced due to mitochondrial injury. The accumulation of reactive oxygen species leads to the attraction of neutrophils, to the induction of tissue damage, proliferation and production of monocyte chemokine protein 1, to activation of P38, MEPK, and ERK, which induce migration and proliferation of vascular smooth muscle cells. Reactive oxygen species induces and triggers the NLRP3 inflammasome, which activates caspase-1, responsible for the maturation of interleukin-1 beta. Mitochondrial damage caused by uric acid leads to apoptosis of vascular endothelial cells and to the development of atherosclerosis. Uric acid can also induce a decrease in endothelial nitroxide oxidase expression, which leads to protein neutralization and lipid oxidation. The reference normal range for uric acid is 1.5 to 6.0 milligram per deciliter in women, 2.5 to 7.0 milligram per deciliter in men. When the level of uric acid is higher than 6.8, crystals of uric acid forms as monosodium urate. Other factors have been shown to be important in controlling urate solubility, such as sodium ions, temperature, pH, and the role of connective tissue. International guidelines support as a pathological cutoff only the saturation part of uric acid get filling to identify specific cardiovascular risk prevention cutoff. In the current literature, the relationship between uric acid with cardiovascular disease has been explored mostly in chronic settings such as, for example, diabetes. Little evidence is available in acute settings such as acute coronary syndrome. The objective of this work was to analyze the association hyperuricemia and ACAs, but also to seek the existence of a relationship between uric acid and other cardiovascular risk factors. For example, diabetes, smoking, renal failure, obesity, hypertension, dyslipidemia, CRP, hyperuricemia in Algerian population. This is a prospective cohort study. The data is obtained after consultation of medical records and by measuring cardiovascular risk factors. The study was carried out at the biochemistry laboratory on patients admitted to the cardiology department. 95 fasting patients are included in our study. Patients taking hyperuricemic and hypouricemic drugs are excluded. We used cobas-Roche diagnostics for determination of troponin, uric acid, total cholesterol, HDL, triglyceride, urea, creatinine, ApoB100, CRP, and homocysteine. For the estimation of LDL, we used Friedwald formula. For GFR, we used MDRD formula. We also calculated the relative cardiovascular risk by the formula of Q-risk 2007. The data are collected and analyzed by SPSS. Acute myocardial infarction was defined as recommended in current guidelines. Results. The sex ratio of our population was 0.9. The mean was 62 years. 30% of patients were diabetic type 2. 49 were hypertensive. 16% of patients were tobacco users. 45 were pre-obese state, and 24 were obese. 33.7% of patients presented confirmed acute coronary syndrome. 27% patients showed uric acid greater than 6.8 milligram per deciliter. RR is higher in 88% of patients, and only 90% of patients have kidney failure moderate. We did not find a statistical significant association between diabetes and uric acid, smoking and uric acid, body mass index and uric acid, and hypertension and uric acid. Even if the association is weak, it seems more important with hypertension and diabetes. No association significant is shown with total cholesterol, triglyceride, HDL, systolic pressure, and RR, except for the concentration of troponin, urea, ApoB100, CRP, homocysteine, and GFR. By gender, we find that only female population has a significant association between uric acid and troponin, triglyceride, CRP, homocysteine, and RR. We also noticed that if we eliminate patients with deterioration of renal glomerular function, the association observed between uric acid and troponin, uric acid and homocysteine decreased significantly. Uric acid is measured in low-income countries. It is accurate, well-validated, and already known by clinicians. The relationship between hyperuricemia and cardiovascular disease is not new. Indeed, it has been known since 15th. These relationships have been confirmed by numerous epidemiological studies. For example, this study shows that the elevation of uric acid is a factor strongly associated with cardiovascular disease. Hypoxia cardiomyocyte necrosis in ACS, we therefore hypothesized that uric acid as a marker of oxidative stress may be useful in the diagnosis of ACS, as troponin in blood is a marker of myocardial cells necrosis and therefore non-detectable until myocardial cells are severely damaged. Uric acid as a marker of oxidative stress preceding necrosis can provide some diagnostic benefit in the differential diagnosis of acute disease. For example, this study indicates that uric acid value below 5.0 milligram per deciliter may be useful in differential diagnosis of patients with acute chest pain, reduce the risk of acute chest pain, and draw clinicians' attention to other causes of acute chest pain. However, there are significant limitations in this study. Uric acid was only available at the time of service presentation and therefore cannot present chronological result. Although uric acid were higher in patients with SCS, it cannot be clearly quantified if they arise from acute oxidation or are chronically elevated in this patient. As shown by our results and as reported by this study, increased level of uric acid was more strongly associated with major cardiovascular events in women than in men. In our study, the association of elevated of troponin T and uric acid was lost after elimination of patients with low GFR. Many research hypotheses that uremia-induced skeletal myopathy may be responsible for increased troponin in renal failure. It's also possible that the smaller immunoreactive troponin fragments are cleared by the kidney, but this remains to be clarified. Indeed, the improvement in renal function after renal transplantation does not reduce troponin. Additionally, the majority of studies have failed to show a relationship between creatinine and troponin elevation. Diabetes is an independent risk for cardiovascular disease. Many studies report Many studies report that hyperuricemia linked to insulin resistance. In our sample and in line with the result obtained by this study in stroke patients, there was no statistically significant association presented association between uric acid and diabetes. This result may be due, as in this study, to the small number of patients. Smoking is a major cardiovascular risk factor. Nevertheless, in our sample, no association was found between smoking and ACS. This result could be explained by the small number of patients who smoke, but also by other factors not taken into account, such as the number of peaks per day and duration of smoking. This study, for example, reveals that the consumption of tobacco is strongly associated with hyperuricemia in female and non-male population. Due to the absence of female tobacco users in our sample, and in accordance with the literature, no association is observed between uric acid and tobacco users. Increased intracellular urate is a key factor in the pathogenesis of primary hypertension. Uric acid induces oxidative stress, renal vasoconstriction, and ischemia. This triggers activation of immune system, which causes persistent renal vasoconstriction and salt-sensitive hypertension. In our sample, the association between hyperuricemia and hypertension was present but weak. This result may be secondary to interference from antihypertensive medication taken by patients. Consistent with our study that showed an inverse association between hyperuricemia and decreased in GFR, it has been shown that uric acid affects endothelial function and may contribute to worsen kidney disease. Some studies have also revealed that reducing uric acid reduces the progression of kidney disease. Hyperuricemia does not present any association with parameters of exploration of dyslipidemia, with the exception of triglyceride, particularly in female population. It should be noted that the average age of female population is 62 years. Indeed, after menopause, the uricogenic effects of estrogen decreases. Recent studies have described a significant association between hyperuricemia and hypertriglyceridemia. This study demonstrates that triglyceride is an independent risk factor for hyperuricemia. The association of decreased ApoB100 in patients with hyperuricemia in our population confirms observation in the literature. Thus, the study suggests pleiotropic effect of ApoB in gout. Indeed, the control of uric acid is associated with genetic variation of A1CF gene, which encodes complementation factors for the catalytic polypeptide of the mRNA editing enzyme ApoB. This enzyme is a part of complex that exists translation coded stop in ApoB mRNA, causing ApoB48 to be synthesized instead of ApoB100. The urate increase in A1CF allele would then functionally associated with reduced ApoB, raising the question of whether reduced ApoB is a risk factor for hyperuricemia. The association between uric acid and CRP is important in female population. This result is in agreement with the pro-inflammatory idea of uric acid. The relatively higher proportion of postmenopausal women may have influenced CRP concentrations. Although the reason of the gender differences is unclear, there are possible explanations such as the differences in lifestyle and metabolic risk factors between males and females. Although the reason of this gender differences is unclear. In fact, in our study, women generally had more adverse risk for atherosclerosis, for example, hypertension, diabetes, and body mass index than men. And these risk factors may be important contributors to the low-grade chronic inflammation. Finally, homocysteine is an independent risk factor for cardiovascular disease. Genetic variation of HFR are linked to increase uric acid. In our sample, the association hyperhomocystinemia and hyperuricemia is appropriate and statistically significant, but remains linked to GFR. The close relationship between homocysteine and GFR suggests that homocysteine is eliminated from the body by urinary excretion, just like creatinine. Conclusions. Several points remain unknown in the relationship of uric acid and cardiovascular risk. It remains to be seen whether uric acid contributes directly to genesis or is just a bystander. It seems that uric acid is more important in elevation of cardiovascular risk in women. Renal function based the result of the study, particularly for factors directly affected by GFR. Nevertheless, he noted that uric acid relationship with ApoB 100 and CRP-US persisted when renal function was normal. The association of hyperuricemia, elevated CRP, and lowered ApoB support of idea of pro-inflammatory and pleiotropic effects of ApoB in gout. Although no significant paradoxical elevation of LDL is observed with decrease in ApoB, puts the hypothesis of the lack of precision of the estimation of LDL by the Friedwald formula in the event of hyperuricemia, which requires other complementary studies. Two questions remains open. The first identifies the target uric acid cutoff. The second question proves the effect of uric acid reduction therapies on the risk of cardiovascular events. For the first questions, studies suggest that uric acid and affect the cardiovascular system at the serum levels below 6.8 milligram per deciliter. Published results from an Italian studies provided a cutoff 5.6 that appeared to be the most appropriate for cardiovascular mortality. For myocardial infarction, similar cutoff emerged according to gender, 5.2 in women and 5.4 in men. Additionally, another cutoff, 4.8 milligram per deciliter, was found to be predictive of fatal heart failure in another studies. The cutoff should be used when evaluated of relationship between uric acid and cardiovascular risk is to date undisputed. Meanwhile, a more appropriate cutoff should be chosen on an individual highly dependent on other cardiovascular risk factors, for example, jaundice and previous cardiovascular events. For the second question, currently therapies are exclusively recommended for patients with hyperuricemia associated with arthritis or nephropathy. Further randomized studies using cardiovascular events have been published, and most evidence is based on preclinical investigation. However, there are currently no data regarding the possible link between these effects and the reduction of uric acid by, for example, haloperidol. Two trials limited to people with gout have been published, CARES and FAST. Drugs compared febuxostat and allopurinol, which have many important biases. For example, the absence of control group. No data were provided on specific therapy concerning other cardiovascular risk factors, and they did not take into account asymptomatic patients with hyperuricemia. And thank you for your attention.